This residency research project is comparison of pharmacist versus nurse-managed heparin infusion protocol in a community hospital. To start off with background, heparin, an intravenous or subcutaneous anticoagulant, is effective for stroke risk reduction, anticoagulation and hemodialysis, acute coronary syndrome, and venous thromboembolism prophylaxis and treatment. Heparins enhance antithrombin anticoagulant activity 1,000 to 4,000 fold, so balancing clinical benefit with bleeding risk is critical. The heparin 10A assay determines the anticoagulant activity of unfractionated heparin by measuring the ability of heparin-bound antithrombin to inhibit the factor 10A enzyme. Pharmacokinetics and bioavailability of heparin may be altered by obesity, pregnancy, aging, renal and/or hepatic disease, antithrombin deficiency, or heparin resistance. Weight-based dosing of heparin is more effective than fixed dosing at reaching therapeutic anticoagulation levels, and adoption of weight-based nomograms has become standard of practice. Health system-wide standardization of heparin infusion protocols using electronic health record-based clinical decision support for nurses has recently been implemented. Pharmacists at our institution had deviated from heparin infusion protocols due to previously stated patient factors when managing heparin infusion dosing regimens. On the right, you'll see an example of a DVT or PE high-intensity heparin protocol with the weight-based dosing and follow-up levels and dose adjustments based on 10A levels. The goals and objectives of this study are as follows. The main objective is to retrospectively assess the differences in safety and efficacy between pharmacist-managed and nurse-managed heparin infusion protocols. Primary endpoints include the number of heparin 10A levels in the therapeutic range and the time of the heparin 10A in therapeutic range as a percentage of the total therapy duration. Secondary endpoints include the time to achieve an initial therapeutic heparin 10A, presence of any bleeding or clotting events, and the number of off-protocol heparin doses as a percentage of total doses administered. This is a retrospective single-center comparative chart review study. Inclusion criteria are the following. 18 years old or above, admitted to the hospital between July 2020 and January 2021. Patients will be receiving the high-intensity heparin protocol with a heparin 10A goal range of 0.3 to 0.7 units per milliliter, and they will have at least 2 heparin 10A monitoring levels drawn during their course of heparin therapy. Exclusion criteria on the flip side are if patients are less than 18 years old, admitted to the hospital outside of the date range for data collection. If the patient is receiving a low-intensity heparin protocol, this was due to the heparin 10A goal ranges changing between the pharmacist-managed and nurse-managed protocols and was excluded for consistency and data analysis. Another exclusion criterion is less than 2 heparin 10A monitoring levels drawn during the course of heparin therapy. Data will be compared retrospectively for 90 days of pharmacist-managed heparin infusion protocol and 90 days of nurse-managed heparin infusion protocol before and after the clinical decision support for nurses was enabled. Deviations from the protocol will be evaluated and assessed along with timing, accuracy, and appropriateness of heparin 10A lab draws. Anticipated outcomes of this study. The main hypothesis is that patients placed on a nurse-managed heparin infusion protocol when compared to those placed on a pharmacist-managed heparin infusion protocol will have similar amount of time in a therapeutic goal 10A range and similar rates of bleeding and/or clotting events. In terms of practice impact, results obtained from the study will provide and strengthen evidence to support nurse-managed heparin infusion protocols as an effective dosing strategy for patients in our institution. Determination of whether significant differences exist in safety and efficacy between pharmacist and nurse-managed protocols will affirm whether deviations from protocol are necessary to achieve therapeutic anticoagulation while avoiding adverse events.